patients who use drugs, patients who use typically intravenous drugs, and the puzzles and challenges that arise in providing care for people under those circumstances. There's a ton of stuff we could do on this topic. Many of you will be familiar with the sort of the normal pattern, and the normal pattern is something like the patient is continues to be a drug user, has got endocarditis or something equally as terrible, requires a significant hospital stay, and often requires the administration of an antibiotic using a PICC line. After the patient perks up a bit, recovers, they make it abundantly clear that they don't want to stay in hospital. Well, maybe that they cannot stay in hospital. That's not an option that they can manage or sustain, and so they seek to leave, and then the puzzle arises about what you do with the PICC line. So some places would not allow the patient to leave, or try not to allow the patient to leave with the PICC line intact, would try to remove it. Other approaches would engage in counselling and support for that patient in the hope that they can come to an agreement such that the patient would be able to be discharged and would not continue to use, or at least not use that method because of the fears of overdosing. All I want to do, I think, is to say that these are some of the most challenging and profoundly difficult cases that I think contemporary hospital care has to deal with. Those issues are recurrent, and what it means to be respectful of the individuality of each patient, I think is really challenging. I think what it means to be a good and careful healthcare provider under those circumstances is really challenging. What the limits and boundaries of responsibility are in all of those cases. And I think I just want to finish there by saying these are the sorts of stories that it makes perfect sense to take through your ethics program, to sort of try to create a space to step back, to allow care providers in the first instance to work out what treatments they're prepared to offer, and the ways in which those treatments can be supported for patients who maybe, again, cannot manage what would be the gold standard of care. So I just wanted to acknowledge that topic was raised in the comments last time. It warrants an entire session by itself, precisely because of that tension between the care that people need and what we've been calling autonomy, the care that they can accept, in the context of a whole bunch of broader social issues. So you'll be familiar with the idea that I think in both Alberta and BC, there are current programs that would allow people with addictions to be held involuntarily. So we typically don't do that in Ontario. There's some fuzziness about that, but typically we don't. We don't hold people on the basis of their addiction and drug use and prevent them from leaving. We tend to take the view that people are capable of making their own decisions, which means that we don't have grounds to hold them. So that's a social debate. Should we create the authority to hold people under those circumstances? How would you unpack that social debate? So what's the relevance of evidence, the success or otherwise of a program like that? How does that help you determine what as a social policy we ought to do next? All right, so think of that as a sort of an acknowledgement. Yes, this is a really big deal. And yes, it is a hugely significant social question that we have not yet come up with anything like a satisfactory answer to. And yeah, maybe the route forward is a whole load of individualized discussions as we think our way through each of those. All right. So today we're going to do death. We're doing end of life stuff. So we're following that program through the life cycle. Let me do the standard reminders. So jump in with the chat anytime. And just turn on anytime if you want to make a comment. Just stop me and please do that. Go ahead. Let's try and make this a bit more conversational. And then there's an evaluation as usual and a request for the certificates at the end. Let's do our land acknowledgement. So we acknowledge that we are on the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Atawan-Daron people. We were based in London. We are right on the banks of the Antler River here. That's where we're coming to you from today. We acknowledge all the treaties that are specific to this area. The land continues to be home to diverse Indigenous people, who we recognise as contemporary stewards of the land and vital contributors to society. What's the thought for today? I can't get away from snow. And my guess is that none of you can either, which got me thinking that climate and weather are an essential component of the land, the lived environment in which we find ourselves, and that has got to make us think about the human impact on our climate. So let me sort of park that as our thought for the day around an attempt at being thoughtful in reconciliation. All right, I want to go back to last week though. Did I switch your screen? Did you see something different now?
Yeah, it did.
We ended with the emergency exception. Did I ask you what you would do? Did I tell you the ED Sharpie DNR story? Give me a nod if I did. No? Oh well, the ED I got a phone call. I got a phone call from an emergency physician, and she said that she had just had a patient brought into her emergency department, and the patient had been found in her long-term care home, found immobile, out of it, unable to respond, unresponsive, and she was holding her DNR, her advanced care plan, advanced directive, which said, of course, do not attempt to resuscitate me. And she'd written in a Sharpie on her arm, DNR. That's why it's called the Sharpie DNR, right? So you be the emergency physician. What do? You should put a comment in the chat. And let me remind you, you're an emergency room physician. You got to do something. So sitting around and thinking about it is probably not the response. So I'm getting nothing here in the chat. Lockie, are you seeing anything in the chat? Yeah, look, see, we're leaping in. Medical care. Oh, hang on. But we're going to not attempt. So I've got some people going with the DNR, and I've got some people saying doesn't apply. Don't know who wrote it. I don't know how many versions of this story I've got. I've got at least two that I think are real. That is actually happened. So you've heard a version of the tattoo. The real versions I've got is this one, and I've got another one that came from another really experienced emergency room physician. His version was suicide note, bottle of Jack Daniels, empty bottle of Jack Daniels, empty bottle of pills, and do not attempt to resuscitate. Let's do. Look, I showed you a health practitioner shall not administer a treatment under Section 25. That's the emergency exception. If the health practitioner has reasonable grounds to believe that the person, while capable, expressed a wish applicable to the circumstances to refuse consent to the treatment. Do you think the healthcare practitioner, the emergency room physician here, has got reasonable grounds to believe, that's the crucial phrase here, that the patient would not want a resuscitation attempt? So I've just got to go through your list. I've got a whole load of, well, I've got both answers. which is exactly what I want. The emergency room physician, reasonable grounds. You see, but not 100%. Belinda, we never. Well, I don't know where Belinda is. Have you ever had 100% of anything? So, what I'm suggesting there, Belinda, is that we really rarely have certainty. Is that fair? That in all of the hard cases, I think in all of the hard cases, you've got to make some sort of a judgment. And what does that look like? What are the grounds for making the judgment? So I've got somebody says it's got to be a document. Oh, that is so interesting. There's a really famous will case about a guy who got run over by his tractor. He ran himself over in Saskatchewan case. The guy ran over himself with his tractor, and his tractor was on top of him, and he scratched "Give all to wife" or "Leave all to wife" on the fender of the tractor. Valid will? Yeah. Yeah, it was taken to be a pretty clear expression of what he wanted. So, look, room for judgment. The physician in the story that I'm telling you then went on to say, "I resuscitated her," because in the emergency department, people act. They the focus, the requirement is that we, that there's action. But then we had a conversation and worked out that probably the next best appropriate thing to do at this stage was to go back to that named substitute decision maker, identify that these were the circumstances under which the patient had been found, she was resuscitated, and then recommend a withdrawal. Recommend the withdrawal of life-sustaining treatments on the grounds that is what it seems to be reasonably clear that the patient would have wanted. And then you get consent to that from the substitute decision maker. Puts a burden on the substitute decision maker for sure. But what you're doing there is, I think, respecting both. All right. That is going to lead us to talking a little bit more about consent, and for certain talk a little bit about substitute consent, and then we're going to go to end-of-life stories, because in a lot of cases the substitute consent piece is going to concern the actions that occur at the end of a person's life. So we are back to the Healthcare Consent Act. This is the definition of treatment: anything done for a therapeutic, preventive, palliative, diagnostic, etc. And it includes, and this next part is significant, a course of treatment or a plan of treatment. So when we talk a little bit more about thinking about people at the ends of their lives, there is sometimes a concern that as a patient sort of nears the end of their life, that they might, well, arrest would be easy, but they might get to a point where they're no longer capable, of making their own decisions. And then those decisions would subsequently be made by a substitute decision maker, and there's sometimes concern that substitute decision maker won't do what they're supposed to do, which is to follow the instructions of the patient. So one way of sort of thinking your way around that would be for the care provider to get an agreement to a course of treatment or to a plan of treatment with the patient while the patient is still capable. So that might then concern the things that will happen, the reasonably foreseeable contingencies. If this happens, then the plan of treatment is that we will do X or not do Y. So I think one of the most significant cases along those lines that I have come across concerned a patient who had voluntarily stopped eating and drinking. So this is somebody who does not have a condition that would allow them to be eligible for medical aid in dying, but they want to die, and they are going to refuse to eat and drink until that occurs. Well, they will become incapable of making their own decisions before they die. And what this particular patient, in conjunction with their healthcare team, wanted to ensure is that nobody thought that they could override that patient's decisions after they became incapable. Does that make sense? So in order to avoid that, they set it up so that there were no decisions to be made, because the patient had already agreed to the plan of treatment that would not include interventions at the time when they became incapable. Does that make sense? What they did is they avoided needing a substitute decision maker by making the decisions before the patient became incapable. Make sense? Give me a nod, somebody. Okay. The little note under here is the Razuli case. So the Razuli case, Hassan Razuli, Sunnybrook story. He had a brain operation, I think, and was determined shortly after that operation that either that he was in a persistent vegetative state or that he was in a minimally conscious state. So there's a bit of fuzziness about what either of those might mean. But his physicians determined that there was no prospect of a meaningful recovery. There's no likelihood. Now look at all the words we get. No reasonable likelihood, no prospect, it is vanishingly unlikely that. So they were pretty certain that he was not going to recover. And so they proposed withdrawing the life-sustaining treatment that he had. He had ventilator support. They went to his wife, who was his substitute decision maker, so he's clearly not capable. And they said, we're going to withdraw ventilator support. And she said, no, I don't agree. I don't consent. And they said, the physicians said, well, we weren't asking you. We're telling you. We don't need consent to stop doing something that isn't working. Does that, I mean, all of the language is tricky, but something like, look, physicians don't ask permission not to do things that won't work. That's ridiculous. If you had to ask permission not to do all the things that wouldn't work, you'd spend your entire lives asking people to agree not to do things that had no prospect of success. So clearly, I mean, that was their argument. That made it all the way to the Supreme Court of Canada, and the Supreme Court of Canada ruled against the physicians. It's a really interesting judgment. It's a split decision. And it works, it relies completely on an interpretation of the Healthcare Consent Act and this definition of what constitutes a treatment. So what the judges ruled was that withdrawing the treatment is itself a treatment. And the reasoning's a little fuzzy, ambiguous, either because something like it requires them to physically do something to the patient. So here they're going to have to do something to him, and or you don't just turn the switch. That in order to withdraw that life-sustaining treatment, you would have to ensure that the patient was kept comfortable because he's still able to experience discomfort and pain. You'd have to ensure that that he was kept comfortable. That meant that the course of treatment was discontinue and palliate. Does that sort of make sense? So the ruling is that you can't disconnect a life-sustaining treatment without the patient or substitute decision maker's consent. The judgment is, I think, especially interesting because maybe the last sentence, the last paragraph of the preamble to the judgment, the judge writing it, I think it's McLaughlin, said, we did not consider the issue of cost because it's not our job. So the job of the Supreme Court of Canada was to interpret the Healthcare Consent Act. And the Healthcare Consent Act itself doesn't talk about the cost. So one really good reason for not providing life-sustaining treatment in cases of people who are in persistent vegetative states, one really good reason for not doing it is that it's a waste of money. That it costs about $1 million a year to keep a person in an ICU. And one argument for not doing that is that if there's no reasonable prospect of the person recovering, then all we are doing is keeping the body alive. And that's a really bad way of spending $1 million a year worth of healthcare money. But that argument can't be made now because of the Supreme Court judgment in the Rasuli case. Does it make sense? Not? Okay. So that's Rasuli. So I'm going to do some stuff on substitute decision making. I've got an hour or more on this. I think I'm doing it in the Niagara region, that full hour piece in a couple of weeks. We did it in Chatham a month or so ago. It's a perennial topic, substitute decision making, the rules that govern it, and the nuances around it. So we're going to go really quickly. In most of this you should know. There's a hierarchy in the Healthcare Consent Act, so you can tell who the person is supposed to be. And there is always a substitute decision maker because the substitute decision maker of last resort is the public guardian and trustee. So, then you sort of go through the list. It is essential to recognize that you only need a substitute decision maker when the patient is not capable of making their own decisions. And I think, as we did last time, we're capable unless we're not. So it requires that the physician or the person proposing the treatment determines that the patient is not capable of consenting to this particular treatment at this particular time, and then you need a substitute decision maker. So you'll all have a ton of stories where the family is standing around the bed saying what should happen to grandma, and grandma is perfectly capable of identifying what she wants to happen to herself. So the power of attorney, it's a document which names a person or persons. You've got to be capable when you do it, and you've got to be over the age of 16 to do it. The attorney, the grantor must be capable, but the person who is named must be over the age of 16, and they too must be capable. So one of the requirements of a substitute decision maker in any particular case are that they are capable of making the healthcare decision that we're talking about, capacity piece. They must also be available and willing to play that role. Whole bunch of people that you can't be. The ones that are most significant are around accommodation. So people who are in group homes, for instance, can't have the owners or operators of the group homes act as their substitute decision maker. You can't be in a professional social work, counselor, teacher relationship. You can't be in a medical relationship with with the patient. There's a form that you can use, but you don't need to. There are different ways of doing it. The form is on the Ministry of the Attorney General's website, and there's a link there. Now, this is the bit that I'm wagging my finger on this bit. This is the piece that I don't know is most often misunderstood, I would say. So there are rules. This is section, I want to say section 26, but maybe I'm wrong. This is right out of the Healthcare Consent Act. The rules are ranked. So the first principle of decision making for a substitute decision maker is that they must, here the word is shall will do. The substitute decision maker must follow an applicable wish from the patient. So they've got to do what they're told. I mean, that's if they know of a wish that is applicable to the circumstances, the substitute decision maker shall give or refuse consent in accordance with the wish. So if you remember, I think last week we identified that the Healthcare Consent Act calls itself an act to promote autonomy. This is autonomy in action. What this section says is that you now, while you're capable, are able to bind what happens to you by instructing your substitute decision maker to make particular decisions on your behalf at some time in the future when you can't do it yourself. We did Millett versus Schulman, the Annie and the Bags of Blood story. I think we did that one. So that's a motor vehicle accident. It's the case that gave rise to the Healthcare Consent Act. The patient had a Jehovah's Witness card. And the judge was completely clear that do not give me blood or blood products card in her wallet was binding, required the healthcare providers around her to respect her autonomy, her prior capable wishes, in the language of what becomes the Healthcare Consent Act. Now, so ranked rules first. What I have said, the wishes that I've expressed concerning the particular topic that we're talking about, and then it says only if, and it is an only if there are no wishes that are applicable under the circumstances, then you look at the best interests of the patient. But the best interest stuff is really interesting too. It's not an abstract idea of best interests, or it's not some sort of objective idea of best interests. It's best interests in the context of the person's values and beliefs. So, if you think for any one of us, is there a way of saying that thus and so would be in all of our best interests? Well, the Healthcare Consent Act says, no, not really. In order to find out what your best interests are, we're going to have to we're going to have to ask you first. And if we can't ask you, then we're going to be stuck looking at your values and beliefs. Can you see how powerful that idea is? It relies on a conception of the person as they are, as they have lived their lives. So this is straight out of the Healthcare Consent Act. Best interests in the context of the patient's values and beliefs. The next part is any wish not required to be followed under the previous section. The previous section was if there's a wish made by the person while they were capable that's applicable to the circumstances, you must follow it. But this covers wishes that don't meet those stipulations. So either they were wishes that were made when the person isn't capable. I think that's what that ends up having to mean. So what does that look like? I've often argued that if we're talking about reinserting the feeding tube and the patient has been consistently pulling that tube out, consistently pushing you away, consistently refusing an offer of food, then that's a wish that's being expressed while the patient is not capable, but one that's relevant to the things that we do next. You okay with that? I think it fits under that section. And then treatment or no treatment improves or prevents from deteriorating the patient's condition or well-being. Well-being is a powerful word there, because it makes you think about the entire person, and you can think of a whole load of situations where an intervention, a treatment, might make a difference to the person's body, but doesn't make any difference whatsoever to their well-being. Balance of benefit over harm, and then least intrusive but equally beneficial. I don't think we're going to do these. All right. I think I'm going to go somewhere different. I think we're going to go to where we should be in this session. What do you think? I switched. You got something different here? This is we're going to go and die now. We've been building up to it, but now we're going to spend a bit of time talking about death. Oh, but you know what? Before we do it, Lockie, do you want to do Eric? Are you there, Locke? Do you want to do Eric?
I could do Eric. Sure.
Go on, you do Eric. Eric is one of our favorite stories. We tell it slightly differently, but I think, go on, Lockie. You.
Yeah. So the story of Eric, and this is based on a real case, but I came across it in an article. This isn't a case that Rob or I worked with. But the story of Eric is that Eric, throughout his life, was, I would use the term, devoutly vegan. So he organized his entire life around the ethical principles of veganism. He would go to vegan rallies. He would never eat or use any animal products whatsoever. He ended up meeting his wife through vegan activism. And he very much lived his entire adult life according to the tenets of veganism. However, later in life, Eric got diagnosed with Alzheimer's, leading to dementia. And eventually his care needs were too much for his wife to meet at home. And so he was put in a long-term care facility. And naturally, when he was put in a long-term care facility, his wife said, he's vegan. So please make sure that all of the food that he receives while in the home is vegan. And of course, the home dutifully was providing him with vegan food, until one day, by mistake, the home accidentally gave him real meatballs as opposed to his usual vegan meatballs. And for the seemingly first time, Eric said, I like these. These aren't what I normally get. I normally get different food from everyone else. Moving forward, I want to get this, being meatballs, i.e. meat. And so the question of the home moving forward was, what do we do? Do we respect who Eric was before he went into the home, when one would argue that he had all of his mental faculties, a good understanding of what meat is, how we get meat, killing animals, and these ethical principles that he lived his life by? Do we go by that and stop giving him meat moving forward? Or do we go off of what he says now, which might not have that understanding, probably doesn't have that understanding of what meat is, and do we allow him to eat meat? So I see Corrine says, give the man a meatball, quality of life. And that's a really common response. And it makes perfect intuitive sense, right? Here's the guy in front of you right now, right? He doesn't know, he doesn't know like meat or otherwise. He just knows what tastes good. He has a preference, and his preference is meat. Why hold him accountable to something that he no longer understands? Peter saying consult with SDM if he is incapable. So food is interesting. Is he capable or is he not? What does it mean to be capable of choosing the food that one eats? Is to be capable Yeah, is he capable to be capable? Does he have to understand what meat is, where it comes from, with reference to his previously held values, or is to be capable of for food to be taste better, or just a gustatory preference? Do we need to go to the SDM at this stage? But bringing back to what Belinda says, he has consented to wanting meat, and people can change their mind. Has he changed his mind? If he no longer has the guiding ethical framework of veganism, it just doesn't exist anymore in his mind. He doesn't understand it. We'll pause it. We'll say that he no longer understands the tenets of veganism. Has he changed his mind, or is he just no longer capable of maintaining that framework of thought? And so there's good reason to provide him with meatballs. He's the person in front of us right now. He wants meatballs. That's what he wants. Let's give him meatballs. But that being said, when he entered the long-term care home with his wife putting him in there, he put his trust, or they put their trust in the home to help him uphold the values, again, which he guided his entire life by, right? These were very, very important, like aspects of who he was veganism in terms of ethical principles. And so is there an obligation to help maintain the thread of his identity by continuing to help him adhere to vegan principles? Sometimes what I like to do is also think about what happens if we change the scenario a bit. Would your opinion change if Eric was instead a Muslim person and the food was pork specifically? Might we think differently about whether or not we uphold his religious views as opposed to his strongly held moral convictions? Some people think that there's a difference there. Mocha, I assume that's the sort of cognitive assessment score. Can be a medical food can be a medical intervention required for life. The home controls food source. Consult a dietitian, and look at anthropometrics. I'd be curious about what you mean by anthropometrics there, Peter. In terms of dietitian, the dietary requirements or needs would be very similar, and I think that the risk of, say, consuming a meatball versus a vegan meatball in terms of like choking hazards and that sort of thing would be very similar. So I'm not sure what information might you be looking for there that might change your decision or impact your decision is what I would be curious about. Lindsay says if they had never made the error, he would have continued to eat the vegan meals. That's entirely plausible, right? Supposedly in the story, when he eats the meatballs, he says I get something different from everyone else. So maybe he was starting to catch on that something was different. But it's entirely possible that if he was never given meatballs, he would never have chosen. I'm going to put in quotation marks, chosen to eat meat.
Okay, I'm going to jump in. There's a ton of stuff. We both really like this story because there's a whole load going on. Well, let me just refer you back to that section of the Healthcare Consent Act that we did just 2 seconds ago. The requirement that a substitute decision maker follows the prior capable wishes. Well, this might not be a treatment decision, but Eric's prior capable wishes are really clear. When he was admitted to that home, he said, he'd said his entire life, don't give me meat. And when he was admitted, his substitute decision maker said, don't give him meat. So if we take the Healthcare Consent Act approach, respect his autonomy, then we're going to say, no, of course he shouldn't get real meatballs. So that's sort of one strand. Another strand is, well, what do we mean by decision making? Here you go. So Aurelius put a poll. You need to commit, people. You get a yes or a no. That's it. And I want to see where you stand. So that's one piece. But let me talk about changing your mind and decision making. Oh, we got 50-50. I told you it was a good story. the decision-making piece is really interesting too. What exactly is the decision that Eric is, or decision choice, I mean, however you want to put that, what exactly is it that he's doing when he says, I like the taste of this? I want to defend the idea that all he's saying is, I like the taste of this, which is a completely different type of decision from the decision that he made around refusing to eat meat because you've got to kill animals to do it. That's a decision that's got a whole load of cognitive components. You need to know stuff in order to say, I don't want to eat meat because it's meat. Which I don't need to know if I say I like the taste of this. I don't need to know what it's made of. So the decisions are, Ivana says sensory versus cognitive. Yeah, that's fine. I think that's a perfectly good way of putting it. So does his sensory override his prior cognitive? is a way of putting that. Now, quality of life. Look. Do you know what, Belinda? I'm going to say no, or at least I'm going to say probably not. Remember when we were doing the Healthcare Consent Act, we said that this is an act to promote autonomy. Nowhere in that act, apart from if you haven't got prior capable wishes, does it talk about anything like best interests of, and I'm tying best interest to quality of life here. I'm sort of imagining that they're connected with each other. So the Healthcare Consent Act isn't an act to promote well-being. It's an act to promote autonomy. So Yvonne and Belinda are going to have to go and battle it out somewhere because they are taking exactly the opposite view. Let me frame the question as, I mean, the way I think I'll often talk about this. Just a minute. I want to do Belinda and the Viva Puff cookies. Belinda, I'm going to say that's different. And let me tell you why I think it's different. The reason, I don't know. Well, maybe I'll do mine. I'm going to go down drowning in good scotch. And you could say, but Rob, that's somehow bad for you. And I'd say, yeah, but I don't care. I mean, it doesn't matter. I want to defend Belinda's dad, who said, you know what? I've reached the point where the Viva Puffs are what I want. And sure, I know that it doesn't fit with my diabetes management, but I don't want to manage my diabetes anymore. I'm done with that. And that's a completely legitimate choice that a capable dad is making here. Poor Eric, that's not his choice. Poor Eric's situation is, here's something that tastes great. But for my entire life, it turns out I've said that I don't want that taste. So Lockie gave you another version of the story. Belief systems, exactly. Another version of the story where the dietary restrictions are religiously based. Does that matter? I think we often find those easier to accept, but it's not clear at all to me that it matters that the belief is grounded in a religious conviction or a personal moral conviction or the way I have lived my life. So I don't think that helps us. But I do think that often people will get the religious restrictions a little easier. I've got a version of the story that relates to sex and sexuality, where the person in the long-term care home is engaging in a sexual relationship that is completely contrary to the way in which she has lived her life, for her entire prior life before she reached the stage of dementia that she has and is now in a long-term care home. So, all right, we've got religion and morality. Yeah, deeply held beliefs. I'm okay with that. For certain, I'm going to say that in Eric's case, his is a moral or ethical belief. He believes that it is unethical to kill animals in order to eat them, or to use them for shoe leather. That's a profoundly held moral beliefs, and whether that has got the superstructure of religion attached to it or not, I don't think really matters. That's who he is. That's the thing he believes in. All right. I'm going to go on. What's the takeaway message? Here's the takeaway message. The takeaway message for Eric and the Meatballs is that, and when we saw that you were voting pretty much 50-50, the takeaway message is that long-term care facilities in particular, our way of thinking about people who have dementia more broadly, is that there's a struggle, a tension between something like respecting the person as they were and something like respecting the person as they are. Does that, I'm getting a nod from Yvonne, does that make sense to you? And the Healthcare Consent Act is respect them as they were. The people who work in the long-term care home have only ever known Eric in the state that he is. And they're interested in how he's doing now, not his esoteric belief system. They care that he smiles. They care that he doesn't go around trying to spear other people's meatballs. So they're typically treating him as he is, and his family are trying to preserve who he was. Right. Oh, you can think about how hard this is for long-term care homes. Many of them will have a person board outside the door. And the whole point of the person board is to say, hey, you see this guy as he is, now diminished, frail, vulnerable. But he used to be, and in some sense still is, the fisherman, the hunter, the dad, the granddad, the boat, just what those person boards are trying to do is to make the course through life continuous. It's to connect the dots of a person. And what we're struggling with the Eric and the Meatball story is, well, how does that work when somebody loses the ability to make the sorts of cognitively rich decisions that are constitutive of the person that they were? How do we honor a person under those circumstances? All right, I'm going to skip a whole load of stuff. Should we talk about death? I think that's what I want to do. Give me a moment. Let me find some stuff here. There are a whole load of slides here about, okay, where does it go wrong? So, if you think about care at the end of a person's life, where are the places where we miss things that we should have done? And there are a whole load of them. I think we don't often enough encourage people to write advanced care plans while they are still capable of doing so. I don't think we push people hard enough to confront their own mortality, to try to think through what's going to happen predictably as they become more frail, sicker, and then die. So I don't think we do a good job of that. I think there's tons of room for improvement. I would say that in a whole load of cases, people get a whole series of treatments at the end of their lives that do them absolutely no good whatsoever and probably do them harm. Go on, I should get nods. I mean, you could probably walk through the ICU in any of your facilities right now and identify people who shouldn't be there, and they shouldn't be there because they're just going to die there. Is that, have I put that crudely enough? Because I wanted that to be just, direct. An ICU is a terrible place to die. anyway, so how do we miss that? You know, you can think of all of the examples that you have of the ways in which we we don't manage to avoid the next sort of logical step, medical step in the treatment of whatever is failing. We miss the looking at the whole person. We treat the screens rather than treating the complete person. So maybe I'm going to do not offering. Maybe I'll do it here. So I haven't got slides on this one, but I've got it somewhere else. Many of you will be familiar with the idea that the College of Physicians and Surgeons of Ontario now, maybe 3-4 years ago, identified completely clearly in their advice to the profession that a physician in Ontario does not need to seek consent not to offer a useless attempt at resuscitation. So the language is a little different. I like the language of futile. The language of the CPSO document is that it's a resuscitation attempt that is almost certain not to benefit the patient. So under those circumstances, the CPSO is completely clear. It's the physician's responsibility to write a DNR, and that does not require consent. It's back to that idea that a physician doesn't need consent not to do something that won't work. So a different way of putting that is to say that the clinical judgment that a resuscitation attempt will not benefit this patient, that clinical judgment falls within the authority of the physician. And that can be made, should be made, does not need the consent of a patient. So I think I'm not sure that that's a shift from previous practice, although many people would think that it is. And I want to defend it. I want to defend that idea that clinical judgment ought to be made, and I think you ought to be supporting your physicians as they try to do that, because sometimes they'll be doing that, maybe even often they'll be doing that against the arguments, wishes of family members. Oh, here you go. This is more of the same stuff. I'm just going to flag withholding and withdrawing. I don't like the withholding word because I think if you say that we're not going to offer a resuscitation attempt, we are withholding a resuscitation attempt, it makes it sound as if we're hanging on to something that we could give but that we don't want to. Whereas I think the judgment is quite different. I think the judgment is that it is inappropriate to offer because it won't be successful. The common sense oncology stuff, I think I've got 6 slides on that somewhere. It's a group from headed by a public health guy from Kingston, from Queens. The sort of main thrust of that group, Common Sense Oncology, is that there are way too many cancer treatments, and I should probably put inverted commas around the treatments, interventions that occur right near the end of a person's life, where there is very, very little prospect of a meaningful benefit, and where the burdens of receiving and providing that cancer treatment are extraordinary. The burdens on the patient are extraordinary, the burdens on the system are extraordinary, and it is almost certainly not to bring any benefit that's worth having. So their approach is to try to get people to take a step back, to think about the patient as a person, and what makes sense for that person as a person. All right, so let me do Rizzoli we mentioned, so I'm not going to do that one again. That's a link to the article. I will talk about, well, maybe I'll give you a quick and dirty on the Waryzniak case. It's what gives rise to the CPSO advice of the profession. So Waryzniak versus Livingstone. Waryzniak is the patient. I think that's right. This is I think it's another Sunnybrook case. He was living in the long-term care home, he had a DNR at his long-term care home, which is many people do. Went into the hospital to have, I think, to have a leg amputated. As was quite common, his DNR was suspended during the perioperative period, right? So that's fairly standard. Anaesthetists typically won't anesthetize if they can't bring the person back if they crash. So the DNR was suspended during the perioperative period. That time was over. The physicians that were caring for him decided that his DNR should be reinstated. Phoned his daughter, who was his substitute decision maker. Didn't get her. They phoned her to tell her what they were doing. Wrote the DNR. She went into the hospital that afternoon, was in her dad's room. Come on, you guess what happened. He arrested while she was there in the room. She was frantically pulling the call bell, and the team arrived and said, no, we're not going to attempt a resuscitation because there's a DNR. She did, she thought that was wrong. She appealed to the college twice, I want to say. She then went to HPARB, so the Health Professions Appeal and Review Board. And then that was taken, because they were mostly, the HPARB ruled in her favour. The CPSO did not. And then it went to the Ontario Superior Court. And the judge is completely clear on this case. It's using the language that we've been using. There is no requirement to offer a resuscitation attempt which the clinician deems to be futile, and that becomes the CPSO policy. So you can get that link there. All right. So we've got about half an hour left. When does a person die? Oh, I should have done this as a poll. Oh, well, too late. So when does a person die? We could, let me do it as a story. I've worked in London at the London Health Sciences Centre maybe 20 years ago, 25 years ago. And they were just introducing a new end-of-life care policy. And it was a policy that was going to systematically ask people on admission what their wishes were around resuscitation. Probably a pretty good idea. But it meant a significant change in the way many people in the hospital setting would be thinking about death, advanced care planning, and advanced directives. So we did a series of education events through all of the sites, including some work at St. Joe's. Now, there were two ethicists working in town at the time. I was one of them. And the other one was a former nun. This is relevant. So we would start all of the sessions that we were doing with a, okay, when does a person die question. And we'd sort of set it up as if it was a spectrum or a continuum. I'm not sure that it is, because it didn't necessarily have an end. We'd start by saying that there would be some people in any room, there'd be some people in this group who believe that fundamentally a person never dies. So those people have got a belief in an immortal soul that transcends the physical body. That belief entails that the core elements of a person, Robitude, transcends Rob's physical body. It makes sense? You're right. That's the whole point of having an immortal soul. The whole point is that non-physical entity survives. In some sense, if I had one, my non-physical entity would survive my physical death. but the key piece is that it's me all the way through. I should get a nod. That's one end. I mean, how do you put that? That goes forever, so you can't really put it on the end of a spectrum. At the other end, there are some people who would say that the person could die way before his body dies. So you can tell that's me, right? Is Eric dead? Eric and the Meatballs, you remember him? I'm getting a no, but you can see what I'm asking. Oh, look, you got one. Oh, well done. Yeah, go on, put this in. So does a person end when my sense of self ends? When my sense of me as the person that I am? Is that when Rob dies? One version. Do I die when my heart stops? Cardiac death. Do I never die? That idea of an immortal soul. Do I die when my brain dies? Are you okay with all of these? Go on. So give us an answer, and let's unpack some of those ideas in a bit more detail. All right. So we're going to do. Oh, let's do this one. We'll do Dead Enough Part 1. So this is donation after cardiocirculatory death. I've got another version of a London Health Sciences story here. The Trillium Gift, again, it's going back 20 years or so more. The Trillium Gift of Life Foundation had just changed their criteria for organ donation, and they just changed them to permit donation after cardiocirculatory death. So this is the situation where the person is on a ventilator support. They are, we think, going to die. They want to donate their organs. The previous approach would be you had to wait until their brain stopped before you could take out their organs. Well, why not turn the ventilator off, then the heart will stop, then the brain will stop, then you can take out the organs. The reason for not doing the first version, just waiting for the brain to stop, is that the organs deteriorate. The organs are getting worse and worse the longer this guy hangs on. So better turn the ventilator off, allow him to die, and then take the organs out. Does this make sense? You should be thinking, oh yeah, that makes sense. So how long do you wait after turning the ventilator off to see if his heart spontaneously starts beating again before you decide that, I've called this dead enough, before you decide that he's dead enough to take the organs? Does the question make sense? Right, so in some cases you turn the ventilator off, the cardiac support off, the heart stops, but then it starts again. So how long do you wait to make sure it's not going to start again? Go on, give me answers in the chat. How dead is dead enough? Anybody giving me a go here? Oh, I've got to look at the right. So the heart is stopped. Oh, so that is Peter. That is, I think, if we're honest, intended to solve this problem. So because, well, so let me sort of unpack this. At the time that we were having the discussion, there were no agreed upon standards. So the group of transplant surgeons that we had in the room were saying things, well, as short as possible, right? We want to get the heart while it's fresh. So 90 seconds. We found a document at the time from St. Mike's, which again is relevant, which said that in order to ensure the moral certainty of death, wait 9 minutes. So you should be thinking, what does moral certainty of death mean under these circumstances? Now, what I'm playing with is the idea that this number is arbitrary. Whether you pick 90 seconds or 3 minutes or 5 minutes, I think the current standard is 5 minutes, but it might be 3. That's an arbitrary number. And it's a bit of a puzzle, I would say, why a person who wants to donate shouldn't say, oh, just take it. Turn the thing off, go, done. There is actually a suggestion, again from London Health Sciences Centre, that we permit made by donation. So you can just sort of imagine that. So at the moment, in order to have medical aid in dying, you have to have it's a drug that will kill you. But the suggestion is that don't do that. Sedate the person, but then allow the removal of the relevant organs to be the thing that kills the person, because then they'll be really fresh. Come on. You should be thinking about this. You should be going, ooh, first, and then afterwards you should be thinking, oh yeah, that's the Belinda thinks that's disturbing. That's the ooh bit. But I want the, oh yeah, maybe that does make sense to come after the ooh. That is, the purpose is to donate. I mean, you know the person's going to die. The purpose of discontinuing life support is to allow them to die so that the organs can be taken at a time when they're still viable, useful. So why not maximize the chances of success? Anyway, go on. You can think about that. So that's the death by donation piece. Let me keep going. Wouldn't we do a different dead enough? So what we're playing with, and you'll get it more clearly with this with the Taquisha McKitty story. What we're playing it with is the when does a person end idea. So we started off with that. Does it end when my sense of self ends, or when something else physical happens at sometime down the line? So let me do Taquisha McKitty. So this is 2019. So these events occurred a couple of years before, so maybe 2018. So Taquisha McKitty, it's another Toronto case, but I don't think it's Sunnybrook this time. She was a young woman who had a drug overdose. So she was maybe 27, something like that. Was admitted to the hospital, was in the ICU, was in the ICU for about a week, maybe 10 days. And her physicians now, everything that I say next has got inverted commas around it, because every word or phrase can be unpacked and thought about in sort of different ways. Her physicians said that she was brain dead. Her physicians deemed her to be brain dead, or she died. You're all right with the way the words are different? Go on, give me a nod. If I said she's dead, that's different from saying, well, her physicians have deemed her to meet the criteria for brain death. Go on, Yvonne's giving me a nod. That feels different, doesn't it? So the family said, no, she's not. I was going to say she was on life support. Is she on life support? Well, she can't be because she's dead. She's on ventilator support. Again, all of the words are tricky here. They said her heart's still beating. There's still blood going around her veins. She's still breathing. She's not dead. So no, you can't extubate. It makes sense so far? So they got a court injunction to prevent the hospital or the physician team from extubating. That court injunction was heard, that case was heard maybe 3 months later, something like that, 3 to 6 months later, during which time look, again, you see, how do I say it? Her body, she is maintained on ventilator support. Her body is maintained on ventilator. The corpse is maintained on ventilator support. The judge in the first case said, yeah, of course she's dead. Doctors say when you're dead, the end. Ruled completely in favor of the physician team. Family appealed. And that's what took it to the Ontario Superior Court. Let's see, have I got, oh yeah, I thought I did. So what happened was that she'd been admitted to the hospital in September of one year. Her heart stopped in December of the following year, so 15 months later. The case had been heard by the Ontario Superior Court, but the judgment had not been rendered yet. So under normal circumstances, that would just end the story. It's moot now because there's no longer a plaintiff. But the judge decided that he would rule because he thought that it was in the public interest. I think he's absolutely right. And this is what he said. I'm going to read it because I think this stuff is terrific. I'm going to do my judge voice. So you've got to imagine really pompous judge. The criteria for determining whether death has occurred is not a technical question that is indefeasibly the province of the medical profession to which the common law must defer. The two criteria for death, cardiac and brain death, have not been accepted by the common law because medical practice is determinative, but because they have been judged by the common law to provide a sound answer to the question of how to determine whether a person has died. So it gets better, but no, Doc, it's not a technical question. It's an entirely different sort of a question. We, the law, allow you, the physicians, to make to say what you say because we think it's a good answer. Here, this is the bit I like. The determination of legal death. What's the difference between legal death and death? The determination of legal death is not simply or even primarily a medical or biological question. Does that sound right to you? Do you think when does a thing die? Is that question a science question? I think many of you want to say yes. The question of who the law recognizes as a human being entitled to all of the benefits and protections of the law cannot be answered by medical knowledge alone. Well, if rights only accrue to people who are alive and this person's dead, then being dead does really answer that question. Facts about the physiology of the brain dead patient are needed to determine what obligations are owed to the brain dead patient. Hold on a minute. If I'm brain dead, I can't be a patient, can I? Because I'm dead. I'm a corpse. Go on, give me a nod. I mean, make up your bloody mind. Am I a living thing, a patient, or am I a corpse, brain dead? But the inquiry is not ultimately technical or scientific. It is evaluative. Who the common law ought to regard as a human being, a bearer of legal rights, is inescapably a question of justice, informed but not ultimately determined by current medical practice, bioethics, moral philosophy, and other disciplines. I will, of course, staunchly argue that whether or not a person is dead is a philosophical question for which medical evidence might be useful, but not according to the judge in McKitty versus Iani. Now, there's one, I think I've got it here. There is more. There's plenty more on that judgment. One of the pieces that gets left open is whether there's a potential charter challenge based on religious belief. that would be available to the current practice of determining brain death. So if you were to argue that my religion tells me when a person dies, and my religion says that a person dies when their heart stops, is that a plausible charter challenge against the idea that a physician can determine that I'm dead on the basis of no brain activity? There's another case. It's the Jahi. Oh, where is it? Somewhere. Jahi McMath. Jahi McMath. She was deemed to be brain dead when she was about 12, and dental surgery, I think. She was removed from a hospital in California and taken to, somewhere. Pittsburgh, I want to say. It was a state where they don't have a law concerning brain death, and her body was kept on ventilator support for about 5 years. She went through puberty without brain, and after it had been determined that she had died. All right, we've got to do some medical aid in dying to finish. We've got 15 minutes, 12 minutes. Okay, maybe Lucky, I'll do this bit and I'm going to throw over to you to do the other contentious pieces to finish. Is that all right with you? You in the mood for that?
Yeah.
So I said, but this is called Made Now, but it's not. This is made in 2023. The annual reports come out in December, the year after the year that they apply. So this is back to the 2023 annual report. Just under 5% of deaths in Canada at that time were medical aid in dying. That's 1 in 20 people. I don't know whether you're thinking, gosh, that's a lot or something, but 1 in 20 people. Contrast that common sense oncology piece, where there's too much treatment occurring with too little good effect. People are sort of locked onto the healthcare train. The contrast is with people who choose MAID. 1 in 20 people make a conscious, active decision that they don't want to do this anymore and that they will seek help in dying. That is only 15.8% more than 2022. So since inception, rates of medical aid in dying have gone up about 30% a year. So 2023 was not anywhere near as large an increase, so there's still a 15% increase. 64% cancer. The suffering part is interesting. So if you ask people why, how do they describe their suffering, almost everybody says that loss of ability to engage in meaningful activities. So another way of putting this is, what makes a life worth having? Well, a life is worth having if you can engage in meaningful activities. And if you can't, then many, many, many people say, that's enough, I might as well be dead. And loss of ability to perform the activities of daily living. The piece I just want to flag here is the frailty piece, which is in that year, 2023, almost 1,400 cases, that is getting on for 10%, cited frailty as a condition, and it was the sole condition in 92 cases. So frailty is a bit of a catch-all, I would say, and it's a condition of aging. So I think that raises interesting questions about, interesting questions about where we go with MAID. All right, Lockie, you under the future expansion stuff?
Sure.
You don't need slides, do you?
No, it's fine. So there's some potential / proposed / in the process of being implemented expansions to MAID. So currently at the federal level, MAID is only for those who have a reasonably foreseeable death, they're dying, or they have a grievous and irremediable physical condition. You also have to be 18 years old, and you have to be capable upon the beginning of the process. And in some very specific circumstances, you can waive final consent just before MAID is provided. But generally, mass majority of cases, you need to be capable at the point of provision of MAID. And so three proposed, incipient, being discussed expansions to MAID is MAID for mental health conditions where a mental disorder is the sole underlying medical condition. So these would be cases where an individual is qualifying for MAID solely on the basis of a mental disorder. This was committed to when MAID was expanded to include circumstances where an individual does not have a reasonably foreseeable death. And it was expanded to those with severe physical conditions. But they gave a year back in 2021. They gave a year to get their ducks in a row to figure out what it might look like to expand MAID to include mental disorders. It's now 2025. We still don't have that. That's still not permissible because they've kicked the can down the road as each deadline approached. On top of that, something that's being considered is MAID is currently the only medical treatment that has a hard age limit of being 18. And so there's some discussion as to whether or not MAID should be expanded to include mature minors, just as under the Healthcare Consent Act, for example, an individual is capable of consenting to treatment if they understand and appreciate the treatment. It has nothing to do with age. So there's some potential for expanding MAID to those who are capable of understanding and appreciating the treatment decision. And then also, interestingly, there is the possibility of advance requests. This is something that Quebec has already done. And so currently in Quebec, you can make an advance request for MAID. And feel free to correct me, Rob, but my understanding is that would be you have to be already diagnosed with the condition and then you can make an advance request. Okay. Yeah. So if you had a diagnosis of something now, you could, in Quebec, that is, you could go through the MAID application process and it could be provided to you at a later date when the criteria of grievous and irremediable condition causing intolerable suffering criteria are met. But that's only in Quebec. It might be expanded elsewhere. So I'm going to quickly, because I only have about 5 minutes, go through some of the interesting ethical, moral pieces for each proposed expansion. So with the mental health or mental disorder side of things, some of the concerns as to why we might not want to expand MAID to include mental disorders is one, are mental disorders truly irremediable? Can they meet that irremediability criteria? And if some can be, how do we determine which cases of mental disorders are irremediable? So for example, there will be people that talk about how they struggle with mental illness or mental disorders, how they might even have attempted suicide, survived, and then gone on to live a life that they value. What appeared to be an irremediable case of a mental disorder, but now they've recovered to the point where they live a life of value. When it comes to MAID, there are no MAID attempts, right? So anytime an individual accesses MAID, there is no chance that they're going to survive. It completely precludes the opportunity to recover later on. And so if we can't reliably determine who will or will not recover later, should we really be providing MAID? That's one concern. Another concern has to do with the capacity to consent to MAID when it comes to mental disorders. This is a really interesting point, Lindsay, and how will that fit with the Mental Health Act? And that's going to get where I'm going next as well. A common thing with individual, or not common thing, but a symptom of some mental disorders might be suicidality, right? Which one might characterize as a pathological desire to die. So the desire to die is not because of the suffering from their condition, right? Which could be reasonable and rational, but rather the desire to die is a pathological urge, we'll say, caused by the condition itself, which isn't rational, right? And the way that the Mental Health Act currently works, as Lindsay points out here, is we prevent suicide. And we prevent suicide by, if we believe that someone poses a risk to themselves or others, we lock them up in a mental health institute, right? And so we very much say, you're not able to make these sorts of decisions, and we'll remove your ability to be an autonomous person, and we'll put you in a mental health facility. Quickly on this topic before I move on, because I want to make sure I give the others some time as well. People that counter these concerns about MAID for mental disorders will say, well, hang on a minute. The criteria for MAID outlined in the Carter case, the very first Supreme Court case that permitted MAID to begin with, outlined 3 criteria. Grievous and irremediable medical condition. Are some instances of mental disorders irremediable? Yes. Okay, I think we can all agree that at least some are. Are we able to determine them reliably? That's a different question, but at least some are. Do individuals with mental disorders suffer intolerably? Yes. All right, I think that's a pretty clear one. They can meet that criteria. Third criteria is able to consent. Well, can some individuals with a grievous and irremediable medical condition, being a mental disorder, who are suffering intolerably, retain the capacity to consent to MAID? At least some will, right? So if, say, for example, someone with a severe mental disorder can still make treatment decisions, right, that aren't MAID. So why is MAID itself different? And so an argument is, if they can meet all 3 criteria, then it should be expanded. And that was the argument or the grounds for this expansion being proposed to begin with. But there are obviously some of those concerns, like I mentioned. In terms of mature minors, again, the question is, what does 18, like what is the requirement of being 18? Why is that morally relevant? Again, for every other treatment, it's the ability to understand and appreciate in Ontario. And so why is there a hard cap at 18? And so that's being explored as well. And advanced requests, this is something that many people want. It's a very popular idea, right? We have it for everything else. You can make an advanced request for other treatments. Why can't we allow it for MAID? And I think the real concern here is that for MAID, there's the criteria of suffering, right? But if I have my diagnosis now and I don't meet the criteria for MAID, how will I know what my condition will be like in the future? And will I be suffering then? And who makes that judgment in the future that I am suffering? And so there's concerns about the ability to predict or project oneself into the future, and how to determine if one meets the criteria such as suffering in those cases. That brings us to time. There's a lot more to say for all 3 of those, but those are some of the proposed expansions.
So I should shut up earlier and let you do more. Sorry, Lockie. But we were. Yeah, but look, we've run hard into the end of our time for all of these. Thank you for sticking with us. Please do the evaluation stuff. That is useful for us. It gives us a bit of an idea about the things that we can do next. Lindsay's question. It's only available in. So those advanced requests are only available in Quebec. They've been available now for a year. It was October of last year that was introduced. I keep hearing that people are thinking about that expansion. It's certainly the case that where Quebec has led, the other provinces have followed. They introduced MAID in general before anywhere else.
I think the big survey that they did last year is supposed to come out soon, where they are asking, the general public questions about specifically advanced requests. So I think there is motion in that direction.
Every time we've asked people when we've done sessions like this, typically people like you say 90% want the option. The ability to make an advance request. It's when you start trying to unpack what that would look like that it becomes, I think, a lot trickier. The Quebec legislation says that the physician, on the basis of their knowledge, skill, and experience, have to determine whether or not I'm suffering at the time that MAID occurs. But that's that's not the way suffering works for every other evaluation. It's dependent on the person, not on an external judgment. And that raises a whole load of questions about the me now, me then stuff. It's another version of Eric. Can I say now that whatever my condition is like in the future, no matter how happy I appear, I would be suffering because I would have lost my sense of who I am. So thanks to all of you. Please, sort of let us know what you think. And thank you for sticking. I suppose I should finally say, don't forget, all of you got an ethics program in all of your organizations. We're happy to participate with you on consults as you're navigating your way through ethically challenging situations. And if you or your teams want to do something on a particular topic, let us know. And I'm sure we can organize something. So thanks to all of you. And thanks, Lockie. And Aurelia, thank you.